Bilirubin is a yellow-orange pigment that forms during the breakdown of red blood cells, which is the erythrocyte. And when old or damaged red blood cells are broken down, hemoglobin, the iron-containing molecules in the red blood cells, is released. Bilirubin becomes the byproduct of this broken process. Bilirubin, when excessively formed in the blood, is referred to as hyperbilirubinemia, which means bilirubin in the blood. But when investigating bilirubin, serum or plasma are used. Bilirubin is performed to investigate serious liver disease and jaundice. It is also performed to investigate patient progress. Example, infants with serious neonatal jaundice. For laboratory investigation of bilirubin, we will briefly go to the lab to see what is done. So let's go.
When a patient comes for bilirubin analysis, we get the patient's blood into the sample container and we spin it in the centrifuge where we get the patient's serum, as you can see. We use this machine, spectrophotometer, for bilirubin estimation using patient's serum. Bilirubin estimation is actually done by 3 methods, which is the manual method, the semi-automated method, and the automated method. Here, we use spectrophotometer, which is the manual method. After reacting patient serum with bilirubin reagent, this is the result we got. This is the bilirubin for normal patients, and this is the bilirubin for abnormal patients. The mixture of patient serum with bilirubin reagents can now be read by the spectrophotometer. The value can now be read on the screen, depending on the color form. The value gotten is now calculated, which is equivalent to the quantity of bilirubin in the patient's serum.
The destruction of red blood cells or erythrocyte can occur due to various factors, and these factors include natural aging. Natural aging in the sense that red blood cells or erythrocytes have a lifespan which is around 120 days, after which they are removed from circulation. Secondly, diseases and disorders such as hemolytic anemia, thalassemia, and sickle cell anemia can lead to the premature destruction of red blood cells. Thirdly, autoimmune disease. In this case of autoimmune reaction, such as autoimmune hemolytic anemia, the immune system targets and destroys red blood cells, leading to its massive destruction. The fourth factor that can affect the destruction of red blood cells is infection. Some infection, particularly from parasites and some bacteria, can lead to the destruction of red blood cells in the body. The fifth factor leading to the destruction of red blood cells is drug. Exposing the body to some medications is one of the factors that leads to the destruction of red blood cells. Factor number 6 is toxins. when the body system gets exposed to certain toxins in the body, it leads also to the destruction of red blood cells, that is the erythrocytes. The seventh factor is the mechanical trauma. The red blood cells, most of the times, when moving through valves and blood vessels, it tends to hit the walls of the blood vessels. In this case, hitting those lumens tends to lead to their breaking and bulging out the hemoglobin. This is another means to which red blood cells are damaged. From the various factors leading to the destruction of red blood cells, hemoglobin are released, and this hemoglobin contains hem and globin. Hem is the iron containing molecule, while globin is the protein molecule that form part of the hemoglobin. The globin, which is the protein part, is reabsorbed into circulation, while the hem, which is the iron porphyrin, is transported to the spleen. The spleen is an organ in the body that forms part of the reticuloendothelial system, the system which helps the body in terms of immune responses, immune defense, and tissue repair. It also helps in terms of immune response regulation. The reticuloendothelial system is a system of specialized cells such as the monocytes, the macrophages, and other cells that are involved in immune defense that are distributed around the body, particularly in organs such as the spleen, the liver, the lungs, and the bone marrow. These organs are found to have played a contributory and great defense to the body. The reticuloendothelial cells is an older name, but a more vague and current name for it is the mononuclear phagocyte system because of the cells that are involved. The monocyte and the phagocyte. These cells do basically three things: recognition, engulfing, and digestion. What it means here is the mononuclear phagocyte system recognizes any foreign material, any foreign debris, any cellular debris, any pathogen that is not part of the body will be recognized by this system. And when they recognize and notice, no, this is not part of the body, they engulf that pathogen, and then they initiate digestion of such pathogen. And if there is any cellular problems or cellular damage, the mononuclear phagocyte system, MPS, initiates cellular repair, and then other immune responses, regulations. Now, as you can see, how the mononuclear phagocyte system plays a crucial role in so many immune responses. Now, the bilirubin that is so formed in the spleen from the breakdown of red blood cells into hem containing globin is further converted into bilirubin. At this point, the bilirubin formed is called conjugated bilirubin. Let me digress a little. When a body is to get rid of anything that is not supposed to be in the body, there is a system that is involved in such removal of this body. For instance, bilirubin that is not supposed to be part of the body can be removed by a way of conjugation. Conjugation means that this particular waste material is supposed to be conjugated with a substance that will make it not soluble in the body, not lipid soluble, but water soluble. Because anything that is water soluble cannot stay in the body, because the body will not tolerate it to get rid of it. But if it is lipid soluble, it will stay in the body even if the body doesn't want it. So the body has a way of conjugating it to make it lipid insoluble and water soluble, and that is what happens to bilirubin. At this time, the bilirubin is called conjugated bilirubin or indirect bilirubin. Bilirubin, to be made direct so that it can be excluded or removed from the body, has to be converted to conjugated bilirubin, which is the direct bilirubin. At this time, the albumin, which is a protein, a transport protein, will have to bind with this unconjugated bilirubin, the indirect bilirubin, and transport it out of the spleen to the liver, where it will be conjugated as direct bilirubin. The bilirubin transported by albumin from the spleen into the liver cannot be excreted. It has to be conjugated. In this process, there is a conjugation that takes place with glucuronic acid in the presence of an enzyme referred to as glucuronyl transferase. The absence of this enzyme, glucuronyl transferase, in certain people leads to a condition referred to as Crigler-Najjar syndrome, a condition in which the conversion from unconjugated to conjugated bilirubin doesn't happen. Finally, the unconjugated bilirubin is conjugated with glucuronic acid in the presence of this enzyme, leading to a byproduct of bilirubin glucuronides, mainly diglucuronides. The conjugated bilirubin is now ready to be excreted out of the body. From the liver, it passes into the bile calonuclei to the bile duct into the intestine. In the terminal ileum, bilirubin is deconjugated and reduced by bacteria into various pigments and colorless chromogen as urobilinogen, most of which are excreted in the feces as stacobilinogen. In the intestine, some of the bilirubin and urobilinogen that have escaped excretion into the feces are reabsorbed through the portal circulation back into the liver, where the same process repeats. The urobilinogen and the bilirubin enters into the bile calonuclei through the bile duct into the intestine, where they are finally excreted as stacobilinogen. The small amount of reabsorbed urobilinogen that has escaped excretion in the feces are carried in the blood through the liver and are transported to the kidney, where they are excreted in the urine. When urine is exposed to air, urobilinogen in the urine is oxidized to a brown color pigment referred to as urobilin. The same happens when feces is exposed to air too. There is a oxidation which takes place, leading to the conversion of stacobilinogen to a brown color pigment referred to as stacobilin. The reason why you see a rapid change in the color of feces or urine when exposed to air. It is important to know that in the urine of a healthy individual, it is only a trace of urobilinogen that is found, but there is no bilirubin.